This is Madge Kaplan, host of WIHI and IHI's Director of Communications. Don Berwick, Jerry Shea, and I have just wrapped up an interesting edition of WIHI focused on ramping up efforts to demonstrate how quality improvement can really and truly reduce healthcare costs and spread the savings around so that payers, everyone, also benefit. So it was an interesting discussion, Don, and we couldn't get to all the questions and comments during this show, so we're offering a bit of a bonus video track, an extended conversation with you just so that we can get to a few more of the questions and hope this is helpful to everyone. One of the questions that came in via chat was from somebody who didn't feel we adequately addressed what do you really mean by lean strategies and quality strategies being on somewhat different tracks, and what does that look like, the separation or the division right now, and what would it mean to really bring it together?
Yeah, I don't think they are on different tracks. I guess the basic point is that the principles of lean production, called the Toyota production system, are core to any modern thinking about improvement and quality itself. It has to do with understanding and addressing the value chain so that every step, that every resource expended, a moment of a worker's time, a piece of supply, everything helps the person you're serving, everything helps the customer, everything helps the patient. I can't think of a principle more central to the overall quality movement. The disjunction is a little more subtle. It has to do with a myth that somehow cost and quality are different things. They're really not. I almost think maybe the word quality needs to be dropped here. It's not a very helpful term. We're talking about what my friend and colleague Gene Nelson calls goodness. It's the goodness of a system like healthcare or care process is reflected in a number of dimensions, things that we want out of that. If you're taking care of me as a patient, I certainly want my symptoms controlled. I'd like to live as long as I can. I'd like to be respected and have dignity. I'd like to be comfortable while you're dealing with me. I don't want to wait too long. I don't want you to look at the color of my skin, or frankly, I don't want you to look at the size of my wallet. Please help me. But one of those attributes is the cost. It's the total amount of resource being used to help me. And if you can figure out with me a way to get me the same help at lower cost, that's quality too. And I think we're ready for a step of maturation there. But let's not separate resource use from the qualities of a system. It's one of them, very important one.
Do you think that part of this may have to do with some way in which people have picked up on lean and the Toyota production system, and that somehow just the implementation and those who have gotten very hot on lean and worked on it, that it's more how this has evolved, that was never the intent of the theory?
Yeah, it's quite familiar. I mean, in the field of improvement, in the 30 years I've been involved, there are waves, fads of interest. Techniques arrive, and everyone gets very excited about them. Re-engineering, statistical process control, lean production now, lean thinking. They're all valuable. It's not in competition with each other. We keep learning new and important things to do, and thinking about the value chain and how every step adds value is very important. So is thinking about, let's say, patient safety and a safety culture. That's important. That's another very important wave. I think mature approaches to improvement in healthcare are going to embrace many, many forms of very, very helpful ways to think. And there's not a derby here. It's more like filling a toolbox.
Mm-hmm. Somebody else wanted you to elaborate more on this concept of flooding the zone. And could you say a little bit more about what are they doing in Jönköping in Sweden that you talked about a complete portfolio? Say a bit more about that.
Well, as the urgency rises, the luxury of sequential thinking, we'll try this, and then if it doesn't work, we'll try that, and if this works, we'll keep it and try that. Although there's obvious attractiveness to that, it's a little bit easier to manage. We don't get overwhelmed. There are a lot of arguments for that. It just isn't responsible socially. It isn't responsive socially. That thinking won't work anymore. We're at least going to have a portfolio approach. The way I've been thinking, as I said in my National Forum speech, is informed by the work on the global problem of global warming. I mean, it's virtually established that greenhouse gases are rising and that we're going to have a serious problem if we don't get them under control. Well, there isn't any one thing to do about that. You could invest in solar power. Still, it helps, but it's not the solution. Same for automobile efficiency. So anyone that wants to think about saving the planet from global warming has to think in a portfolio terms. There's probably 15 or 20 things that we have to do, all of them. And I think the same is now true in the healthcare improvement world. And around cost containment in healthcare, there isn't one strategy that's going to work. It's a lot of things all together are going to have to be brought to bear. That's what I mean by flooding the zone.
Related, and I think you also mentioned this in your forum speech, and somebody asked about it during the program, that you've previously discussed this pricing, he's calling it pricing failure wedge, as a drive for increased healthcare costs. So this person is asking, how do we develop a system that fairly values heroic therapies that are very costly but produce very little health benefit? That's the way the question was posed.
Yeah. That's going to a very hard part of the cost problem. I think the philosophical answer, and I believe it, is we need to preserve resources so that we can afford, so that we can invest in these heroic, miraculous new forms of therapy. Now, they themselves need to be subjected to the question of do they really help? There's all sorts of bells and whistles that are added to healthcare equipment and procedures that don't help at all. They just make more money for the company that makes them, which may believe in it, but the evidence isn't strong. But the way to afford the miracles is to harvest the resources from waste elsewhere. It's a reinvestment. Maureen Bisignano talks about this as she describes in a very eloquent lecture we probably ought to somehow connect people to, where it's the recovery of waste can then be reinvested in those things. How it nets out, I don't know. There certainly are health services researchers who believe, well, it won't be enough. We're going to have to make some tough calls. It's things we just can't afford. I actually am not sure that's true. If we have the discipline to subject new technologies and procedures to scrutiny for their effectiveness, and if we have the discipline to harvest waste out of the system, which exists at a high level, I think we might have enough to buy most, if not all, of the new technologies we really do want.
I think a lot of people found the concept of return the money very provocative and very appealing. I know we're not quite there yet, but what might it look like if you're a major healthcare system and you're in a community and really thinking about the whole pie for everything? What role might you play?
Well, from the healthcare producer's point of view, the answer is quite simple, which is reduce your price and your total cost to the system you serve. I mean, there's a certain amount of money being spent on you, or you and all of your colleagues in serving a community in a health economy. That number would go down, measurably down. So that's the discipline that Jerry is talking about, as he's arguing maybe healthcare producers should be reporting on what they're doing to reduce costs. From the viewpoint of the payer, which is not the insurance company, we're talking about the employer and the employee and the taxpayer. From the viewpoint of the payer, they would experience this as a lower number on their paycheck, less money going in, less than they expected going into the healthcare side. It's a serious discipline. The other problem to keep in mind is now I'm really kind of waving my hands a little bit at another problem, which is economic dislocation. I mean, with healthcare being labor intensive and enlisting 17 or 18, soon to be 20% of the economy, to say reduce that is going to involve a lot of dislocations. We're going to have to figure out a way through that. Job retraining, reallocation of the workforce, and stranded capital. Hospitals that begin to realize they may have overbuilt.
Right. We didn't get into that. That was kind of the elephant in the room. That question sort of fell off, which was really, can we sustain a $2.6 trillion industry, or should we? And somebody asked a question: what will the healthcare system? I was looking at your crystal ball. What will the healthcare system look like if we do a good job of cutting costs? Can you paint that picture? How would it look different?
Well, starting at cost, there'll be a rational proportion of the economy will be devoted to healthcare, and it isn't where we are now. I personally think there's a lower number that would be plenty to meet every need we want to meet, not deny care to anyone, and it's below 17% of the GDP. But at least healthcare costs rising at no more than the economy is growing, is kind of getting its fair share and no more of the care, of the resources. On the care side, much better care. I mean, ask a person today with a chronic illness who's seeing 3 or 4 different doctors and going in and out of hospitals what it's like, and they'll describe often a kind of chaos, a sort of nobody's got my back, I'm not remembered, I keep having to tell them my name and my medications, I feel forgotten. I go home and my primary care doctor doesn't know what's going on. No, one of the things is that people who have that kind of need would say, now there's a symphony. Now this is coordinated, so that experience will be much better. Fewer patient injuries, much lower risks in hospitals and clinics, fewer administrative hassles. We are billing ourselves a lot right now on administrative complexities that we just don't need. And so the care system, I would imagine, would have doctors and nurses reporting they get to use their time to see patients instead of filling out endless forms. Less fraud. And on the pricing side, prices that look more rational. Like, why would we be spending 10 times the price, the money for an image in the U.S. from another country? What is going on here? Is that really because it's so much better here, or because that money is being devoted to research and development? No, it's just silly.
Don Berwick, this has been a wonderful opportunity to have you on WIHI. We're in a kind of brave new world of trying to connect a lot of these dots, too. So thank you very much. It was a real pleasure to have you on WIHI, also to include Jerry Shea from the AFL-CIO. And we invite people to, when we post this, make some more comments, and we'll keep this discussion going. Thanks very much.
Thank you.